Welcome back. We will continue off with different differential diagnoses of the presentations of AAION. With these symptomologies, AAION has a lot of differential diagnoses. It can be malignant hypertension, which is resistant to a lot of hypotensive meds. There could be diabetes mellitus, retinal vascular occlusion, the BRAO, compressive lesion from the back of the eye. There can be collagen vascular disease, always syphilis, as well as herpes zoster. Systemically, there can be migraine or massive blood loss that can cause these symptoms, and also normal tension glaucoma can present with decreased vision or constricted visual fields in the late stage. Some of the history and the physical exam that will be important to rule in AAION is the ophthalmic history, paying attention to the erectile dysfunction drugs, amiodarone, and the obstructive sleep apnea, so ask them about sleep quality, and also if someone else had come with them, any signs of obstructive sleep apnea. Physical exam, we can check the visual acuity, color vision, as well as the Amsler grid. This is demonstrated in the top right picture there. If on any point of the grid the lines are wavy or discontinuous, this signifies a problem. And also look for pupils and test test for RAPD with the swinging light test, as well as ophthalmoscopy. Make sure to do a fundoscopy as well. If you're suspicious that the patient has AAION, ESR and the CRP is crucial. We should investigate those two markers as soon as possible. In terms of vitals, we can take blood pressure. That's especially important. We can also order CVC, look for low hematocrit and high platelets as an acute phase reactant. Also look for fasting blood glucose for diabetes mellitus possibly, and VDRL and FTA absorption test for syphilis, and ANA for vascular inflammatory disease. Further investigation upon confirmation of suspicion can be temporal artery biopsy. This may be inaccurate because GCA forms skip lesions on the temporal artery, so the lesions are not continuous. We can also investigate with the fluorescein angiogram for any choroidal infarct. Choroid is the layer right outside of the retina, divided by the Bruch membrane. Treatment of AAION is systemic steroids. You can give methylprednisolone IV 1 gram per day for 3 days, and it's important to check the blood glucose and the chest x-rays before that. Steroids tend to increase the blood glucose and suppress the immune system so that the chance of pulmonary infection is more likely. So it's important to make sure that the blood glucose is well controlled and there are no pulmonary effusions or any symptoms of focal lung infections before administering steroids. If there are, and treatment is crucial at this point, we need to manage these conditions as well. After methylprednisolone, we switch over to prednisone at 60 to 100 milligrams per oral each day and taper it off very slowly. We cannot decrease it more than 2.5 to 5 milligrams per week. Otherwise, the patient can go into steroidal withdrawal syndrome. Because the AAION is an emergency, the steroids can be started before the biopsy results are seen. For systemic steroids, it would be thoughtful to add an H2 receptor blocker or a PPI because there is a slight risk of a peptic ulcer with steroids. Unfortunately, AAION has quite a bad prognosis. The visual recovery is rare, and the treatment will hopefully prevent the progression of the visual impairment. And the fellow eye is also involved in 75, 3/4 of the cases, and if not treated, as quick as within 2 weeks. Here is a well-drawn flowchart to demonstrate everything that we've learned in this presentation. And here are the references for that we've used to compile all the information in this presentation. Thank you for watching this video.